Well, good afternoon, ladies and gentlemen, and a warm welcome from a beautiful Cape Town. It gives me great pleasure this evening to welcome our guest speaker, who's Dr. Malikah van der Schyff. She's somebody that needs no introduction, and she's the immediate past president of SAMS. So she's going to be speaking about testosterone and mature women's health. It's a very topical topic, and we look forward with great pleasure and great anticipation in hearing Malikah van der Schyff, who is in private practice at the Constantiaberg Mediclinic, doing her presentation. The topic is sponsored by PharmaForce, who have just launched a product which will be referred to by Malikah in the talk. In 2 weeks' time, we're going to be hearing Dr. Suleiman Halen speaking about IVF or surgery for your patient with endometriosis. Remember that next week is the beginning of the Easter long weekend, so we won't be having, because of the holidays and people being away and going on holidays, we won't be having a talk next Thursday. The Zoom will be postponed for a week to the 24th of April, when Suleiman Halen will be doing the honors. So, ladies and gentlemen, Malikah has said that you may interrupt if you wish with questions, but everything will become clear. I must say everything will become clear. Everything will become clear as the webinar progresses, and you can very welcome to ask the questions at the end. Without further waste of time, it gives me great pleasure for Malikah van der Schyff to share her slides, and a great thank you to Chris for doing the technical side this evening. So Malikah van der Schyff, testosterone and mature women's health, immediate past president of SAMS. Malikah, thank you very much indeed.
Pete, thank you so much, and thank you for that kind introduction, and thank you to you and Steve for the invitation, and to Chris for helping with all of the gremlins and things. Chris, are you happy? You can see my slides, you can hear me clearly, we can carry on?
Carry on, everything is perfect.
Happiness. Great. So thank you so much to everyone who attended. It's my pleasure to chat to you about testosterone and mature women's health. These are my disclosures for some of my health advocacy work and my involvement. I have no conflicts of interest except to say that I have quite a few contributors to my talk. This is not my talk alone, not by a long shot. This is not my extreme field of expertise, and I have had resources from our South African Menopause Society, which I would encourage many of you healthcare professionals to join. From the International Menopause Society, I will be referring to ISWICH, which is the International Society of the Study of Women's Sexual Health, and also referring to our 19th World Congress on Menopause, which happened in October 2024, last year. And the top two are the gurus in testosterone management, and some of their talks as well. I would also like to thank PharmaForce and Lawley, which are the pharmaceutical groups where some of the research has been done about that, and mostly to some of my SAMS Council colleagues and friends, especially Dr. Percy Moodley, who is a guru in this area and who I've taken some guidance from as well. So, another disclaimer is to say that this lecture is going to use male and female and cisgender pronouns. The focus is on heterosexual, as most of the research and all of the therapeutic options to date were developed within this context. And I acknowledge that the absence of quality and also just ethical research in many other spheres on non-sexual, on non-heterosexual and non-binary individuals or population is of significant concern and does need remediation. But for now, we're talking about heterosexual. This is a sponsored talk, as you know. This is a sponsored talk by PharmaForce, and it is aimed at highlighting a newly available product that is currently in South Africa and has been for the immediate short while. It is a SAHPRA-registered testosterone cream for postmenopausal women. And this has been very exciting for many of us in the mature women's health field as well, because women's health, women's libido, women's sexual needs have not been paramount up there. I mean, Viagra's been here for a long time from a male point of view, but for women, it has not been here. And if we look at the timeline of where things have come from, Between 2018 and 2019, we know that we've had the global position consensus and position statements on the use of testosterone, and this has not only been by IMS, but by ISWICH as well. And this statement is behind the treatment principle, and a lot of the statement will be highlighted. You'll notice as you see down there, it says Androfem, Androfem, Androfem. That is the name of the product in Australia, who has had it licensed since 2021 and has had done a lot of meta-analysis and research around it, and key data that I will be referring to as well. So that's the timeline which has taken us there. The objectives of the talk is to look at the classification, the epidemiology, and the models of female sexual dysfunction. And I've put there in red that I'm going to do this briefly because we do have time constraints, and I do want you to be home before the sun sets here in Cape Town. I'm going to examine the efficacy and safety of the product that is here in South Africa, or testosterone as it is, for generalized acquired hypoactive sexual desire disorder, HSDD, in postmenopausal women. We will look at evidence-based literature and things around transdermal testosterone, and look at, especially for us and for healthcare practitioners, the current clinical practice guidelines and what you need to do within your practice and how is this going to work. So if I talk about female sexual dysfunction, we know that most of the national studies that have been done prove that older women do experience a lack of interest in sex and in desire. We also know that a big majority of them also have trouble lubricating, and you know this is easily remedied through topical vaginal estrogens for genitourinary syndrome of the menopause, and there have been many of us who have spoken about this topic as well. So that's interesting. There are lots of different nomenclatures out there, newer ones I might refer to as well, where sexual disorders are concerned. And as I said, the International Society for the Study of Women's Sexual Health does talk about this, but for this talk and for my purposes, I am talking about hypoactive sexual desire disorder. And going into it, the definition of it is, and it's there, which is 2016 definition, it manifests any of the following for a minimum of 6 months. And often when patients get to you, it's been much longer than this. It's the lack of motivation for sexual activity that is manifested by decreased or absent spontaneous desire, decrease or absent responsive desire to erotic cues or stimulation, or the inability to maintain desire or interest through sexual activity. It's the loss of desire to initiate or even participate in sexual activity, including behavioral responses such as avoidance situations that could lead to sexual activity that is not secondary to your usual sexual pain disorder. And this is combined, this is very important, with clinically significant personal distress, which includes that entire wealth of emotions that are there: frustration, grief, guilt, incompetence, loss, sadness, sorrow, and worry. And there are other ways to define it and specify it as well. And this can be either through DSM, through ISWICH, through other qualifiers, even your ICD-10, ICD codes. So it can either be by onset, it can be by context, or by characteristics. So it's either would be durational, situational stresses, whether it's lifelong, whether it's acquired. We know that there is decreased sexual desire, and this has been shown in a lot of population studies that have been done in adult women, and we know that this does happen in midlife. We also know that the prevalence, and this is unpublished data, but the prevalence of low sexual desire and sexual-related personal distress are interlinked. And it would be interesting that you notice there that the personal distress at 80 is going down when your low sexual desire is practically at its peak. But I think that might be self-evident. We also know that if we look at it in our studies, it is prevalent in midlife and in midlife women. And it's been shown that it can be greater for women who are actually partnered, who are sexually inactive, even within those partnerships, who are more educated, and who are sometimes taking psychotropic drugs. But we'll break that down as well as we go. So the other thing is what I had mentioned earlier is to know the negative effects of menopause-related vaginal discomfort. And although this talk is not about estrogen, it is important to note that there is a big negative effect on sexual life, and some of this can be remedied by addressing genitourinary syndrome of the menopause with your topical vaginal estrogens. So we know that this is a circular model. We know that it's a circular incentive-based model and not a phase-based model. You know, you have desire, you get aroused, you have sex, but it's not that phasic. You know, the model that shows this incentive-based shows that, for example, emotional intimacy might motivate sexual neutral patients rather than spontaneous desire. So in other words, what I'm trying to tell you with this kind of model is that it's complicated, basically. What is the science behind things? How does HSDD affect the brain? And if we look, the brain controls desire differently in women with hyperactive sexual desire disorder. PET scans have shown that women with sexual desire activate their right brain where sexual arousal is, and they deactivate their left brain, which is the daily activities, when shown erotic stimuli. Women with HSDD show minimal changes in any of these areas, indicating weak activation of the right hemisphere and less deactivation of the left. And this may lead to muted responses to sexual cues and perpetuate inhibitory pathways. However, having said that, low testosterone levels are linked to decreased sexual desire, but does not necessarily predict hyperactive desire disorder. So if we look at the neuromodulators regulating female sexual desire, it is a seesaw. It's between inhibitory factors and excitatory factors. And it is trying to balance those where that's concerned. And it is when these inhibitory factors, you know, when there's shifts in these balance, when there's obviously a change in this balance, that we end up having problems. And the key to treatment is to modulate these neuromodulators and try and get their balance back to where it's supposed to be. And if we look at the mechanism of action of some of the treatments, whether your treatment is biopsychosocial CNS agents or testosterone therapy, which is there at the seesaw, if we look at the pre-treatment and inhibition, the inhibitory systems reduce the activation of the excitatory systems in response to sexual cues. But if you look at post-treatment and you look at what you're trying to change, the excitation, all treatment modules are hypothesized to modify the neural pathways regulating sexual desire. And I will refer to some of this later, but in response to sexual cues and stimuli, the excitation system is more activated, obviously. And this leads to decreased activation of the prefrontal cortex and increased activation of the medial preoptic area, the ventral tegmental area, and the nucleus accumbens. So this is a lot further north than what we usually as gynecologists are working. And we need to realize that it's not about north and south. It is about the entire biopsychosocial model, which many of us, when I was just starting at medical school, this was becoming a trendy thing to say biopsychosocial. And now we know that it is a part of a lot of treatment modalities. And here they've actually included in this Venn diagram is the interpersonal as well. And it's also, you can cut up that pie a little bit further and look at other contributors to desire problems and look at it as whether it's interpersonal development history, contextual, you know, expectation of negative outcomes, lack of appropriate stimuli. So what I'm basically just trying to highlight is biopsychosocial. So when we look at the process of care for hyperactive sexual desire disorder, the guidance, as I said, came from the 2016, and they've updated those things as well, from their practical guidelines. And there are clinical practice guidelines for the use of systemic testosterone for hyperactive sexual desire. And this can be found on their website as well as IMS, which also has guidance onto the use of testosterone. So this one slide is practically the entire talk. So it's going to be what we're going through. The idea is that you want to discuss this with your patient. You want to screen them, make sure that you have the correct diagnosis. You actually need some labs, which I'll go into further. Then it's about prescribing your testosterone, your transdermal testosterone, monitoring how the patient gets on it, and how you eventually do your monitoring short and long term. And I'm going to break this down as we go. This is also another way of looking at it, that the patient presentation, you need to talk to them, you need to get them to volunteer this information or practically drag it out of them. And it's been shown that the prevalence rises in reporting sexual problems when we actually ask about it. So it can go from 12 to 48%. And I'll break that down as we go as well. So this is the flow diagram that Ipswich has for the process of care. I've broken it down a bit more linear there as well. But if we look at the process of care for the management of it in women, this is it about, and a lot of your initial part is about making the diagnosis. A lot of it there you see popping out at you is education, counseling, and referrals, or looking at biopsychosocial. And some of you might be raising your eyebrows and thinking, oh, really, do I have time for this in my practice? But I'm going to try and break it down so we can talk about it. So if we look at it, at the initial part of process of care, it's initiating the conversation, asking the permission to discuss it, finding out about those issues and problems. So that is the initial part of the graph. The idea for screening and everything is to normalize it, to normalize your conversation, to talk about it. And most of you know, your patient is not going to volunteer it. Like one of the slides showed, only about 12%. And sometimes if you ask, maybe 48% of them will actually volunteer things. But you know how it is in your practice. You've just dealt with whatever it is that they're dealing with. And all of a sudden, when you put your hand on the door after you're already running 17 minutes late, then they go, do you mind if we talk about my sexual concerns? So you might as well please start the conversation early and prevent that delay in your consultation time by addressing it. So if there's not a lot of time for you to just look at these open-ended questions or these questions and using those as examples, there is actually a decreased sexual desire screener, which is a validated screen to look at. And the idea is it's got 5 questions, and question number 5 has 7 other sub-questions. But the idea is if the first 4 is yes, and the last 5 are no, everything in question 5 is no, then you're screening positive. And I'm going to break this down with some examples again. This is just another way of trying to display it when we're talking about those first 4 questions. And if you're going to remember nothing about this slide, remember the QR code in the corner. You're welcome to take a pic of it, and it will give you digital access to that screener. And again, so question 4 is about answering it yes to get to see if it's consistent with the diagnosis of generalized acquired HSDD, looking at everything else, and then that would meet the criteria. And question 5 assists with a biopsychosocial review to identify any modifiable factors or etiology that would impact sexual desire. And there are modifiable factors as listed here that can impact it. There are medical conditions. There are, as simple as, is she on a combined hormone contraceptive and later on in life? Is there evidence of treatment of androgen excess? Have we excluded malignancies that might have be hormonally dependent? What about her thyroid? Looking at all of those. So have we actually looked at depression? Is depression treated? Can you treat hyperactive sexual desire disorder if you haven't actually treated depression, So again, going back to the busy flow diagram, if we break it down a little further, we're looking at everything with modifiable or non-modifiable factors. And where does that put you? Is it just education? Is it something that can be changed before we do that? So recommendations regarding full assessment of female sexual dysfunction before starting it is basically everything I've just said. Make sure you're asking the right questions, and that decreased sexual desire screener is there so that you can do that. As I said, the first 4 must be positive. The last 7, which is part of question 5, must be negative for modifiable and non-modifiable things. And the bottom line about all of this is it boils down to biopsychosocial, and to judge whether or not testosterone should be initiated only after full evaluation of that and management of any other conditions that could be contributing. There are medical conditions that can impact sexual function, and you're welcome to grab a screenshot of this. You know, some of them arrive with thyroid, diabetes, metabolic syndrome, obviously the malignancies, spinal injuries that can have issues around various aspects of sexual function. I'll pause a little longer in case somebody wants to photograph that. There are medications that have impact, you know, which includes anything from anticholinergics, antihistamines, obviously the narcotics, hormone preparations as well that can have an influence from a biological point of view. And then, of course, as I keep going from psychosocial, we've got psychological and interpersonal things like anxiety, poor self-esteem. There are also situational and environmental issues like your relationship issues, relationships, religion, family values, taboos, you know, all of those things. So again, this talks about treatments should follow a biopsychosocial model, and pharmacological options, psychotherapy, multimodal therapies can be combined when we're trying to deal with this. If we look at treatments and hypothetical mechanisms of action, obviously I've said biopsychosocial practically every 28 seconds now. So we know that that's there. We know that testosterone is there, and that has androgenic and estrogenic effects where that's concerned. We also know that there are certain drugs which are not available to us, but some of you might have worked out of the country would recognize them. There's something called bremelanotide, forgive me for mutilating it. It increases your dopamine, and that tries to help there, which is a subcut injection. There's something called flibanserin, which is available only in the US and Canada, and works on multiple serotonin receptor agonists and antagonists, and decreases the serotonin and thereby increases your norepinephrine and your dopamine. And then there are 2 drugs that might be here with us, which are for anxiety and anti-anxiety and anti-depression, and that's buspirone and bupropion, and those have similar names, but they basically work on dopamine and norepinephrine and eventually increase it, and that is the mechanism of action for trying to change HSDD. So what are the key messages that we need to know where testosterone is concerned? Because obviously that's supposed to be the focus here. Is that androgens, including testosterone, are essential hormones for the development, the maintenance of female sexual anatomy and physiology, and the modulation of sexual behavior. We know that testosterone has many physiological and pathophysiological actions in women, and I'll talk about that as well, directly through cell-specific receptors, but also by non-receptor mediated actions and by conversions peripherally into estrogen and 5-alpha dihydrotestosterone. We know, and I will talk about this again and unpack it, there is no serum testosterone level for diagnosis of hypoactive sexual desire disorder or for the use of the treatment. There's no cutoff point. However, we do talk about testing testosterone, and I will talk about that as we go. So if we get to testosterone, where are we? We know that testosterone gets produced, at least 50% of it will be produced by the adrenal glands and by the ovary. We know that if we look at the sex steroid pathways, that peripherally, it does get reduced by 5-alpha reductase to 5-alpha dihydrotestosterone, which is what's circled over there. And the important thing to remember, especially for us as gynecologists and for those here, is that obviously testosterone can also be aromatized into estradiol in peripheral tissue and also in the ovaries as well. We must also realize that fat is important in androgen production and reproduction, and that's why sometimes you find that some patients would be too thin to menstruate, or it would influence these pathways and things like that. And I will unpack some of that as well. So we know that testosterone is the primary androgenic hormone in women. We know that it and 5-alpha reduced metabolite dihydrotestosterone activates intracellular androgen receptors and modulate gene transcription. So in men, it's responsible for normal growth and development of male sex organs and for the maintenance of their secondary sexual characteristics. And in women, they act directly via androgen receptors in tissues such as bone, skin, fibroblasts, hair follicles, and sebaceous glands. And I'll show that in a diagram as well as we go. And we know that it is a precursor hormone for estrogen biosynthesis in the ovaries and at extragonadal sites peripherally like brain, cardiovascular, and adipose tissue. So this is where we say the influence of testosterone, and it can actually be a man or a woman over here. So eye health, cardiovascular health, circulation, bone health, reproductive health, cognitive function, mood, muscle, metabolism. And so that's why we talk about the fact that the influence of testosterone can be on many other factors if it is taken as a replacement. But for the function of this talk, we're talking about its registered evidence-based function on HSDD. There are some studies being done on some of this. There is an unpublished study on cognitive function, which has shown that testosterone supplementation has actually helped with all of those. And you know from giving it to some of your patients that they do respond and tell them they feel better. So again, the ovaries and the adrenal glands do not store testosterone. Once it's produced, testosterone is secreted into the blood, where it is rapidly adhered to the protein sex hormone binding globulin. And I'll talk about that in its tests going on. Again, we know that up to 99% of testosterone produced in the body is bound to sex hormone binding globulin. Once testosterone is bound to this, it is inactive actually. So testosterone, which binds to which sex hormone binding globulin does not attach, is actually the biologically active testosterone. And I'll talk about that as well as we go when we're measuring SHBG. And again, circulating testosterone levels do not approximate tissue levels and do not reflect treatment where that is concerned. So there is this graph that you can see that looks like a hockey stick as well. And it shows what we know, that in the lifespan of women, testosterone decreases. What is a bit of a stumper is we don't know why it's a hockey stick. Why does it actually sort of more increase as you're heading towards really the later ages of 70s and 80s? We do know, obviously, there's a relationship between age and androgens in many studies. All of them are declining as we go. So when we talk about testosterone levels and diagnosis of female sexual dysfunction or its treatment, the global position statement from IMS and ISWICH says no cutoff blood level can be used to measure circulating androgen to differentiate women with and without dysfunction. So you're not using it really to make the diagnosis. However, it may help to predict treatment efficacy. And that is ISWICH with their clinical practice guidelines have looked at it as well and said that there is no blood level that is a treatment goal for testosterone therapy, as concentrations do not predict treatment and efficacy. But I know I am going to tell you about testing it as we go. So the main reason to test it is to exclude women with mid-range to high, according to the assays used, levels that suggest that the androgen levels are being associated with the patient's symptoms. And it's to monitor testosterone therapy to ensure against supraphysiological values and androgen excess, because you know that's the biggest thing your patient's going to tell you. She's going to tell you, I don't want my voice to change. I don't want unwanted hairs or things like that. So what is the target testosterone level in most postmenopausal women? There's not really a true answer to that. It's and I'll go through that as well as we go. But if we go back to the process of care, this was one of the slides I showed you earlier on in a different way. Discuss, screen your patients we've spoken about. What about the labs? What are you going to prescribe and how are you going to monitor it? So if we look at the labs, for prescribing this, we talk about doing the labs more regularly as a baseline, then at 3 to 6 weeks, then at about 3 months, and then at 6 months. And you're measuring total testosterone, which hopped off the screen there, and SHBG. So if we're looking at those measurements, we use total testosterone as the biologically active fraction. Using total testosterone, evidence regarding free testosterone as a biological active fraction is lacking. So total testosterone needs to be measured with high accuracy and reproducibility using liquid gas chromatography and tandem mass spectrometry assays. So you need to make sure that your labs that's the way that they are doing it. The direct assays for the measurements of total and free testosterone are highly unreliable in the female range. The direct assays are appropriate to exclude high baseline concentrations. And again, what I've mentioned before, to exclude supraphysiological concentrations to prevent your excess. So the labs that I have checked with that I do use that. What about sex hormone binding globulin? I've just spoken about how it binds to everything. Sex hormone binding globulin is an alpha-2 globulin of liver origin. We know of interest, it increases with oral estrogen, and there's no effect with transdermal estrogen. So it does bind up testosterone. So it remains stable. SHBG remains stable across age ranges in healthy patients. Most testosterone will bind to it. Some of it will bind to albumin, and 1 or 2% is free. Bioavailable testosterone is either albumin bound plus free testosterone, which interacts with target tissue. And we look at the baseline SHBG to influence circulating testosterone during therapy. So if you have a high SHBG, you have lower free testosterone, as I mentioned earlier, about the binding and the active tissue. So it's less effective therapy. If you've got a very low SHBG, this complicates serum level interpretation, rapid tissue clearance, and may falsely suggest poor absorption. And sometimes we increase it so high that the patient ends up not having a hot flush or a night sweat in the estrogens, but then they end up having absolutely no interest in sex. And for example, PCOS is a whole different conversation, about all of this. So if we look at the baseline lab interpretation, when we're looking at trying to write up a transdermal testosterone like a Testofen, use total testosterone, use SHBG, know your lab, use the same lab. If you know the patient has a high testosterone level, you need to go look at your diagnosis again, because then is there really hyperactive sexual desire disorder if there's a high testosterone? Or, there are biopsychosocial factors, but you need to look at your other contributory factors. If you're looking at your SHBG above reference range for age, you need to reevaluate things. Like, is she on oral estrogen? Should you be changing to a transdermal? Do you retest it? Should you be checking thyroids and things? And then we get to when we're going to start writing up medication. SHBG in the reference range for age, or testosterone is in the range, you can still write it up, or a low SHBG, you can still write it up as well. And I'll talk about how we write it up now. What is the efficacy?
Malikah,
I'm listening.
Sorry, Malikah, I'm just getting a bit behind in our questions. The first question from Veronique is, at what stage during the day do you test? Does it matter if you take in the morning, the afternoon, or the evening? What time is better to measure testosterone? And should it be fasting, or does it not matter? If you can answer that one, then we got one.
Yeah. Fasting doesn't matter where that's concerned. And it's mostly, I just want to go back to one of my other slides here, that secretion follows a diurnal rhythm and it rises and falls over an over 24-hour period. Production occurs during the night and early morning with level highest on waking. So I would do it in the morning.
Okay, and it doesn't matter if
And
you're fasting.
fasting and not fasting does not matter because it's not involved in its absorption. So thanks for that one, Veronique.
And then Katrine Middleton says, since most menopausal women have reduced libido and are not happy about it, would it not be fairer to call the syndrome the hyperactive sexual desire syndrome of the menopause rather than disorder, which is pejorative?
Yeah, Kate, this is a group of huge amount of people. I agree with you because I always end up having to remind myself hypoactive. So I agree with you. Nomenclature is different. If you look at how we got from vulvovaginal atrophy and GSM, it was an entire room of people to come up with it. So I think we might see changes that'll come when these people get into a room together and get locked up and decide that maybe they must change the nomenclature. It's the evolution of these conditions, because you'll see later on when I talk about other things, they really do end up, they're trying to really describe it as, for lack of a better word, as descriptive as they can. So I agree with you. Yeah.
Okay, thank you. Thank you, Malikah.
So the efficacy of testosterone, what do we know? We know that in massive meta-analysis, what does it show? It shows that whether they are naturally or surgically postmenopausal, whether or not they're on concurrent other menopausal hormonal therapy, be it estrogen or estrogen and progesterone, we know that testosterone significantly increases sexual function, including sexual event frequency, desire, arousal, orgasm, pleasure, responsiveness, self-image, and most importantly, because this was very important in the diagnosis as well, distress in postmenopausal women. That is from some of the biggest meta-analysis that was done by Lawley or in Australia. If we look at IMS, we know that there's good data for the efficacy and safety of the treatment of HSDD with testosterone in natural and surgical menopause, whether or not you're on any other menopausal hormonal therapy. We also know that the efficacy and safety of testosterone can be used alone in menopause for that, but it is recommended that conventional menopausal hormonal therapy is commenced before testosterone when we are dealing with HSDD as well. But, and it's important to ensure that the woman is well estrogenized in what I mentioned before, especially vaginally, locally, before their libido is enhanced in any other way. So IMS brought that out. IMS also in their global statement goes back to biopsychosocial for management. So who do we treat? The candidates are postmenopausal women with a decline in sexual interest and, of course, distress where they're seeking treatment. We do say that even although the global position statement endorses testosterone therapy only for postmenopausal women, Ipswich and their clinical guidelines talk about late reproductive years, that if there is a decline in androgens and which is supported by the physiology of a decline in androgens and efficacy data. So late reproductive years, postmenopausal women. So there's insufficient data to recommend it for premenopausal women, unless we're talking about premature ovarian insufficiencies, so they're not premenopausal, they're just younger. So early menopause is important as well. So for example, if you're talking about premenopausal women, they talk about look at your modifiable factors, like for example, stopping your combined hormone contraception. And this is what I was talking about, Kate, is there's so many more nomenclatures coming out there. Transdermal testosterone has not been tested for the new DSM-5 diagnosis of female sexual interest and arousal disorder. Please do not ask me, people, what's the difference between FSIAD and HSDD. Ek weet nog nie. I'll get there, but not for this talk. Who is eligible? This is just breaking it down again in a different form. Postmenopausal woman, whether you're using menopausal hormonal therapy or not. POI, total testosterone levels less than or equal to the median of the lab range, and more importantly, patient symptomatic. there is no upper age limit, so there's no window of opportunity or stop at X time. Please be cautious with your athletes. They need to be aware of the rules in their sport and their industry related to androgen use. So be important there, and we'll talk about what we're going to monitor as well. What are the contrary?
Sorry, Malikah,
Okay.
just go back to that previous slide.
That one.
Yeah,
Diana.
that one. Yeah, Diana. Postmenopausal woman currently using, now these are who's eligible. Postmenopausal woman currently on menopausal therapy, single or combined therapy with HSTD. The next one appears to contradict that. Postmenopausal woman not currently on MHT, single or combined.
So it's not a IMS says start them on menopausal hormonal therapy. Definitely look after their vaginas. Ipswich says as well that even if they're not on something, if you've proven with that flow diagram of HSDD, it can be one of the first things that you start with. And the analogy and the idea behind that, Pete, is that a woman is not just going to talk to you about her libido. She's also going to talk to you about her fatigue, her anxiety, her forgetfulness, her foggy brain, her vasomotor symptoms. So that is the idea behind all of those. So I think it is that the one is not necessarily mutually exclusive, but IMS has recommended that they would say, try your menopausal hormonal therapy first.
Okay, I got it. Thank you. And there's another question here from Moira Stein. If a patient still complains of decreased libido on Livifem and Vagifem, can one add testosterone cream to that combination, or better to change what? Or better to change and then add the testosterone? What is your response?
I have done that. Added the testosterone, made sure that they are estrogenized always, which is always in my practice from a GSM point of view, but I have added it to a Livifem. And then we're going to go through what the monitoring is to make sure that you're still okay there. And, you know, looking at your sex hormone binding globulin there as well to see, should you be, although, I mean, Livifem is not officially not an estrogen, but to kind of look, should you be changing the formulation there as well? But I have added it to that.
To Livifem. Thanks very much.
If you look at who's contraindicated, I mean, there's Captain Obvious down here at the bottom, children less than 18, pregnancy and lactation, women of reproductive age, but the others are, you know, much more so-called relevant. You know, your cancers, renal disease, you know, if you're clotty, then that's just it for you, unfortunately. And of course, an allergy to testosterone or anything that might be in a preservative like a tree nut of like almond oil. So what are the adverse effects of testosterone? So if you look first at the safety, before all of those, we know transdermal routes avoid first pass effect. That is for many things, and leads to more physiological and stable serum levels. I like this statement where they say there is safety data to support treatment titrated up to 50% above the upper limit of their lab-reported reference range for premenopausal women. So this has been a statement because it's been shown that if you up their levels from a lab point of view to excess, you actually get a negative effect. Yeah, because you're kind of thinking, okay, great, if I'm, you know, how high do I get her? How high do I get her from a lab point of view? We know that it's well tolerated, just by the way, and right at the bottom it says testosterone does not appear to stimulate the endometrium, which is true, but do remember that testosterone does get converted peripherally as well, and in the ovaries it can go to estradiol. So monitoring your endometrium, I would still do just as an effect. And that's part of the monitoring coming later on. There are no changes in the lipid profile, renal function, and blood indices, but it's not a bad idea to have those as your baseline, but it would probably be part of your menopausal screen anyway, so it would be there. And obviously in women with a risk for breast cancer, everything is a caution. And most of the biggest systemic review and meta-analysis of treatment in women have shown that transdermal testosterone is not associated with increased cardiac events, blood pressure, or venous thromboembolism. But the things that are going to bug your patient are these ones: acne, increased hair growth, alopecia, voice change. You know, that is what they say. I mean, this week alone, somebody said, oh, but I don't want to sound like a man. I don't want acne, that kind of thing. Potential adverse events from excess dosages, other than the ones that were mentioned there, you're also dealing, you know, the virilization that we spoke about, weight gain, nausea, vomiting, jaundice, swelling of the ankle, electrolyte imbalances, persistent headaches. That's other than the ones that I'd mentioned already. Potential pharmacological interactions. This is a busy slide that for time, I'm not going to go through everything, but you're welcome to take a snap of it and just look at it for a reference. But you need to look at some of your other medications and things like that. So there, Moira is looking at tibolone and saying monitor your symptoms and adjust the dosage of testosterone cream where required, looking at your SHBG and looking at the clearance. So it doesn't say don't use it, but it just says make sure your monitoring is appropriate and looking at your symptoms. So I've spoken about the transdermal, the one that's now available in South Africa, which makes us very happy because some people have been getting away with using male products. And there's a caution when prescribing male licensed products or compounded transdermal testosterone. So if you're looking at Livifem, and I'll talk about that later, if you're looking at Testafem, which is its brand name in South Africa, you end up, the rep has come and has a lovely little pamphlet that I'll show you, which tells you all about these application site. Ideally, they say upper thighs or buttocks, because they say in case your children are hugging you and they touch your arms. So that's why they said upper thigh and buttocks. Start at a lower dosage and increase it and monitor it. So the starting dose would be 0.5, which is 5 milligrams. It comes with its little syringe. Maximum dosage is 1, but we only talk about titrating it after about 6 months. And the pack comes as a 50 ml tube. And as I said, it comes with a pamphlet, and the pamphlet has that switch process of care flow diagram that you can look at as well, and talks about only prescribing it when you've gone through that entire flow diagram. And again, if you're looking at evaluating it, you're measuring your total testosterone serum-wise, your SHBG, you're doing it at 0. At 6 weeks, probably 3 to 6 weeks, 12 weeks, you're looking at, is your dosage where it should be? Is the patient noticing anything? Should you be increasing it higher or lower? So it's taking a while to get to that and then increasing it. And it does come with the little pamphlet that they give you with those tick boxes to remind you about doing the bloods and monitoring it at those stages. Other than monitoring it, obviously, it's the other mature woman's health things. Breast exam, pelvic exam, assessing your endometrium as well, evaluate, especially if there's abnormal bleeding, evaluating for the side effects and having your profiles as well, even although it does say in the literature that it's not supposed to have influences on that. It's about monitoring it and looking at for safety. So this is the entire pamphlet that the reps would bring to you, and I found it very helpful as well, you know, and I've kind of broken down the whole lecture into something like this. If we're going to other things, because I'm now focusing on transdermal, a SAPRA registered transdermal in South Africa that has been in Australia and some other countries longer than that. What do we know? Compounded so-called bioidentical testosterone therapy cannot be recommended due to the lack of evidence for efficacy and safety. Those of us who know SAMS knows that we've mentioned this before. And during my presidency, which just ended about 5 weeks ago, we brought out a SAMS position statement on compounded menopausal hormonal therapy. And many of you have used it. Some of you have come and said that it's been very useful for giving it to your patients and for helping you. The drug companies for the menopausal hormonal therapies have all taken this and the IMS statement and has actually used it on their on a lot of their pamphlets as well to say it's not recommended. And, we presented this at the IMS Congress, the 19th World Congress on Menopause, and it was so well received. People were so happy that a society could actually bring out a statement that could be used by healthcare practitioners, that speaks about it. And we spoke not just about what our guidelines were, but what your medical, legal, and ethical challenges were if you were to do that. So that is available. That's available on the SAMS website. You can talk to me about it, and we can always send it to you. If and what's happened. Skus toch, Piet?
Sorry to keep interrupting.
Not at all.
Don't want to fall behind.
Yeah, I'm almost. Yeah.
Veronique says, Veronique has been prescribing Idexis testosterone. I don't know what Idexis. Do you know what Idexis testosterone is?
I must tell you that I have shied away a lot from the male products, short of using the one that I have put here. So
anyway, she says, does she have to change? Is Idexis the male testosterone? Does she have to change over to Testosterone now? And I suppose the answer must be yes.
Look, this is a sponsored talk, so if I say yes, you're probably going to think I'm being paid for saying yes, but the dosages are a little easier. I was taking a photo of this one, which is the androgel that most of us have been using when we had nothing else available to us, and many of us were too scared to use the other testosterone. And I mean, just trying to logistically use it. So I would probably say logistically, it's going to be easier for your patient to have that smaller dosage, smaller treatments as well. But obviously that's a relationship between you and your patient as well to see whether they would change it. But it is very reassuring that you have something that you can now use, that you don't have to say, please put Prestic onto this, please go get a insulin syringe, please only draw up 0.0 something and then use it, and then you worry that the patient's going to get too little or too much. So I think the answer is quite evident.
Okay. Someone said Idexis is a compounding company. Okay, well, that fits in
that
with
answers that question. Yeah.
Yeah. Graham Birdsley, how widely available is Testosterone in South Africa?
Well, I am hoping that the reps are some of the staff from Farmer Forces here. I know I have written it up for a while now in Cape Town and have found the patients have not come back with a classic out of stock. It doesn't exist. The pharmacist doesn't know where it is. And yeah, you're welcome to, for lack of anything else, if you don't find them on the internet by just Googling Farmer Force and finding your local rep, you're welcome to come through the SAMS secretariat, and we can always guide you in your province to who might be your rep in that area.
Thank you. Thank you, Malikah.
Yeah. Then the other things is most of us know about the compounded testosterone. We know about the pellets, which, some of us are still, some people are still using it and women are not wanting to get there. And you worry about supraphysiological dosages. And then there are things that are not really as much available here, like vaginal DHEA. But these are the things that, we're saying are not as recommended because of, for HSDD. So again, it's a testosterone cream that's available here. The take-home message is it's a transdermal testosterone that's moderately effective for HSDD in late reproductive age and postmenopausal women. You start at a low dose and you can titrate it and eventually get to 1. We know that to maintain total testosterone levels in the physiological kind of premenstrual range to diminish adverse events and to optimize CNS and peripheral sexual responses. And as I mentioned, it's actually interestingly been shown that if you increase that testosterone and it shows up on blood higher, you actually go back to symptoms coming back. Again, I've spoken about the compounded ones and the male products like your IM injections. And if it is totally unavailable, then 1/10 of a standard male transdermal dosage. And there is a male version of this, which is different. So there's a blue syringed bottle, and then there's the pinky one.
It would be.
And the important thing is you and I both know that it's more than just sex. They will have urogenital effects. It does have an influence on estrogen and the other menopausal symptoms, body weight, lean body mass, skeletal composition, mood, and cognitive symptoms. So it does have an influence on that. I'm happy to take more questions, and I thank you for your attention.
Malikah, it's been a wonderful talk. You've presented it beautifully. Your slides have been absolutely clear, and we've had lots and lots of questions. Percy Moodley, your friend, our friend, says Testosterone is available in Durban. And thanks, Percy, for that. A question that just come up here on my WhatsApp. Do you have any idea how much it costs, and what is the cost for 6 months worth of therapy?
Oh, Griet Getreide, ek weet nie daai ene nie. That one I really don't know. I should have done my homework and looked at that, but I don't know.
Well,
if
I think it's about
one of the reps, they're welcome to put it in the chat box, please.
Yeah.
Or in the Q&A.
I think it's about 3,000 or 4,000 rand. So it's.
Let's ask Google. Yeah.
I hesitate to use the word reassuringly expensive, but remember that the other testosterone is expensive, and if you're going to go for a testosterone injection in men, it costs also 4,000 rand. So I'm hoping someone can give us that cost. Someone from Pharma Force is able to answer that. And while we're waiting for the Pharma Force lady to come on, I spoke to Dr. Basson about the cost. Now, I mentioned the cost to her, and she says, in general terms, if it's effective, women will pay quite handsomely for the privilege of having an effective agent available nowadays. So, ladies and gentlemen, I'd like to, on behalf of the Pelvic Floor Foundation, warmly thank our presenter, that's Dr. Malikah van der Schyff, and also for her time, and also, of course, for Pharma Force Testosterone for sponsoring this, and for every one of you for being present. Now, here's another answer come up. This is
and for actually bringing a product to South Africa when nobody was interested in women's libidos, short of using a male product. So,
yeah,
you know, the feminist side of me is happy for that.
Yeah. And very finally, because we've just run out of the bandwidth time, just to remind you that in October of this year, we have the FIGO meeting. It's here at the CTICC next door in Cape Town. Special group discounts are available. So although on the face of things, it might seem to be expensive, if you get 30 of your friends together, or even 15 of your friends together, you have a handsome discount. So you get 25% discount of the registration fee if you get your 30 friends or more together. So it's
is that VAT inclusive or VAT exclusive, and will it be at 15% or 15.5?
No, are you talking about Trump's tariffs? Is that what you mean?
No, I was meaning the registration fee.
Oh, I thought you meant Donald Trump's tariffs at 15%. No, his tariffs don't apply, Malikah. You get this is I'm not sure about VAT. You'd have to speak to your accountant about that. What I can say is that in June the early bird registrations close, so you do have time to look at that and collect your pennies together. And also a final thing to get away from FIGO is in 2 weeks' time on the 24th of April, we have Suleiman Halen, our friend who's presented many a time before. He's speaking on IVF or surgery for your patient with endometriosis. So, ladies and gentlemen, a warm thank you to all of those that have logged up.
Pete, may I just please put a plug in there, please, guys? Don't forget the UCT ONG refresher course is also running in 2 weeks' time, from the 25th of February to the April to the 27th. So please go check it out on the website. UCT ONG refresher as well. So allow me to abuse my space and just say that as well.
No, you've got wonderful speakers. I have checked out I will be attending. And we've got Professor Phil Steer, and we've even got Errol Norwitz. I don't know if anybody remembers him. Errol Norwitz used to be my registrar, and Phil Steer, he used to be my registrar as well. So it's a wonderful speakers and presenters, good topics, and well worth the effort of going to Century City. Is that where it is, Malikah? Century City?
That's right, Century City CC, ICC. Yeah, the Century City ICC.
Yeah,
Yep.
that's not the CTICC, it's the Century City ICC, and it's there shouldn't be traffic. People always ask me about traffic. Is it on a weekend? It's on a weekend, isn't it,
It
Malikah?
is on a weekend, so we thought that if you want to write it off as a business expense as well, you can bring the family. They can spend their time on the waterfront, and you can come and get your CPD points and your education for the year. Well, not your education for the year, but most of your CPD points, that is, since we know HPCSA is coming after all of us. So yeah.
Yeah. All right. So, ladies and gentlemen, thank you once again, Malik. It's now on the nose of 6 o'clock, thanks to Chris and to Farmer Force and Test FM. A warm welcome. We look forward to seeing you in 2 weeks, please. 2 weeks, same time, same place, and safe journey home. Good night.
Thanks, everyone. Good night.